And we are in a time, a very historic time. It's very, very exciting to be a part of the changes that are happening here in Oregon. On March 2nd of this year, Governor Kitzhaber signed Senate Bill 1580, which really launched the whole effort around coordinated care organizations that I think is going to better serve Oregon Health Plan members with a focus on improved health. Now, if they're going to do that successfully, it's my belief, and I hope the belief of our panel members as well, that they're going to need a robust public health system to help them do that. Achieving better health outcomes at lower cost and transforming healthcare delivery, public health has a lot to add to that mix. Some of the areas where I think public health is likely to be quite influential include promoting prevention and designing and running prevention programs. The CCOs are going to be functioning under a global budget, so to the extent that they can reap the rewards of prevention, it's going to help their bottom line, in addition to being the right thing to do. Community-based prevention. Prevention doesn't just happen in the healthcare provider's office. It also happens to a very large extent where we live, work, and play. And so out in the community, those kinds of prevention programs, public health knows how to run those programs as well. Health assessment, very, very important. We're going to hear, I'm sure, more about the measurement aspects of the CCOs. But public health knows a thing or two about epidemiology and how to measure health status. And finally, health equity, very, very central to what public health does, to our vision for moving things forward, and that as well is a core part of what the CCOs are going to be addressing. So we are really, really fortunate today to have what you see here is the A team. This is really the state's leading experts on this topic. Before I introduce them, though, I do want to thank several people who made this event possible. The OSU College of Public Health and Human Sciences that helped with our programs, the Oregon Coalition Against Domestic and Sexual Violence that helped us with our flyers, and then, of course, within the Health Authority, many people in the division. Our ASL interpretation was provided by our immunization program, and then our Health Security Preparedness and Response program as well, with the technology around the webinar and the conference call that we're having. So really, let's just have a round of applause for all of those folks who helped make this possible. Okay, so we have very distinguished panelists, and I'm going to introduce them all at once. And the format we're going to use, I'm going to allow each of them a few minutes to make kind of an opening statement. Then we have a set of questions that I'm going to pose to them, and then I hope, we'll have some time for some Q&A and back and forth with those of you in the audience. We do have the ability for those of you on the phone to text in questions as well, so we'll be looking for those questions also. Okay, so to my left here, most immediately, is Dr. Bruce Goldberg, who I think all of you know as the director of the Oregon Health Authority. He began as the director of the Department of Human Services in 2005. And when the Health Authority became its own entity, Dr. Goldberg moved over to become the director of the Health Authority and really has been key in all of that work. His appointment was, as director, was made permanent in February of 2011, and he's had a very long history of working in the area of health reform here in Oregon. He was the head of the Oregon Health Policy and Research Office. He was the medical director for Care Oregon, and also for those of us in public health, we count him as one of our own. He was the health officer for Columbia County as well. He's been a faculty member at OHSU for more than 15 years also. So Bruce has really been leading the charge around CCOs for us in many, many ways, certainly within the agency particularly. And I think we're very lucky to have him here to speak with us today. To his left is Tricia Tillman. Tricia is the director of the Office of Equity and Inclusion within the Health Authority, and she's served in that capacity since 2009. She has worked in a variety of ways to increase opportunities for communities of color, immigrants, and refugees to promote health and human services equity. Now, prior to coming to the state, she was employed by the Multnomah County Health Department, where she started the Health Equity Initiative and the African American Sexual Health Equity Program. And she also serves on the Portland Parks Board. To her left is Dr. Mitch Greenlick, a state representative. He serves in District 33, which is northwest Multnomah County and northeast Washington County. And he's been in the Oregon House since 2002. He's chaired the House Committee on Health Care since 2007 and also sits on the House Committee on Land Use and the Ways and Means Subcommittee on Human Services. Now, Dr. Greenlick has a very distinguished career prior to coming to the legislature as well. He was a nationally recognized health services researcher and also was an administrator at Kaiser Permanente for 30 years and a professor at OHSU as well. In 2005, Dr. Greenlick received the Public Health Genius Award from the Community Health Partnership and the Lifetime Achievement Award from the Oregon Public Health Association. So we're, again, very fortunate to have Dr. Greenlick with us today as well. To his left is Muriel DeLaVergne-Brown. Ms. DeLaVergne-Brown has been, has both a nursing degree and a master's in public health, and she's the administrator for the Crook County Health Department, and I think is a terrific spokesman for many of the issues that our local health departments are grappling with around this as well. She's been active in public health issues locally, statewide, and nationally, and really has been a leader. She is a native Oregonian. She's lived in Bend since 1998 and has worked in public health through nursing school and also as a public health manager. Over 25 years she's been in the field. So I think she knows a thing or two about public health. So Muriel, we're very grateful you're here as well.
Thank you.
And finally, to her left is Dr. Mike Bonetto, who's the Senior Health Policy Advisor in the Office of the Governor of Oregon. He is currently a board member of the Oregon Health Policy Board and the Deschutes County Public Health Advisory Board and Mosaic Medical, which is a federally qualified health center in Central Oregon. He's the current president and co-founder of Health Matters of Central Oregon and has really a very impressive portfolio of past healthcare policy and planning experience. And some of the things that he's done include he was the vice president of business and community development for St. Charles Health System. He was the senior vice president of planning and development for Clear Choice Health Plans. He was the director of the Oregon Health Policy Commission, senior policy advisor to the Oregon Republican Caucus, and policy analyst for the Oregon Insurance Pool Governing Board. His PhD, by the way, he's a real doctor, unlike me. He has a PhD in health policy and also a master's in public health from Oregon State. So with that rather long introduction, I am going to shift over and give each of the panelists a couple of minutes, 3 minutes, and Emily, I believe your timing.
First off, I'm thrilled to be here, and particularly thrilled that I've been promoted to the A team. So hopefully I've brought my A game.
A minuses.
You know what Mel didn't say in the introduction is that I've been working for Dr. Greenlick in one capacity or another since I came to Oregon in 1991 and joined the Department of Public Health and Preventive Medicine. And I can't shake him. And it's been one of the highlights of certainly my professional career to work with him. Now he's in the legislature, I have to say that. On a serious note, I talk a lot around the state these days about health reform and about coordinated care organizations. And you know, primarily it's a lot to community and the healthcare delivery system, not as much to the public health community. And it's great to talk to the public health community about what we're doing around health reform, because I think one of the biggest issues, and I think one of the things that doesn't get enough attention around what we're doing around health reform here in Oregon and around CCOs, is that I think for the first time we're very publicly and explicitly stating that the goal of our healthcare system needs to be health. And that's clear. It's absolutely explicit in everything that's come from the governor, from the agency, and from the legislature, that this is about three things. It's about improving health. It's about the ability to have an affordable, sustainable healthcare system. And it's about improving the experience we all have in that system in one way or another. And this focus on health, I think, is really paramount. Mel indicated that, I've worked in public health. I've worked in, individual care. I've done a variety of things. And, to me, this is really the first time that I think we're explicitly unifying the goals of these what have often been very disparate parts of our healthcare system to focus on health. I think it's a huge opportunity for us as a state. I think it's a huge opportunity to really transform our healthcare delivery system. And I think it's a real opportunity to transform our public health system.
Tricia?
So I also want to say thank you very much for the opportunity to be here, and happy Public Health Week to everybody. I am a native Oregonian, although my mother would argue because I wasn't actually born here, but 6 months later I came. But I fell in love with public health actually when I was living in Tucson, Arizona, and working at a community health center. So when I think about the intertwine between public health and healthcare and health systems transformation and the potential, and why I'm very confident that we can reach our goals, is because I feel like I've seen it. I've seen it in the community health center movement that started because of huge inequities that were happening in the more traditional healthcare system, that local communities were able to organize. They were able to build diverse leadership and on their governing boards. They were able to provide culturally specific approaches to health, linguistically appropriate approaches to health, utilize community health workers and healthcare interpreters, and that approach really intentionally married a clinical environment with the community-based and the social determinants of health. And that's really how I found out that public health was even an option, a career option for me. And so I feel like I still have this passion for public health. I still am in love with public health, and I think that this work that we're all embarking on right now, beginning today with a Healthier Oregon, it is an opportunity really to be intentional about connecting community and clinical delivery in a way that can improve health for all Oregonians. I think that as part of that, and we'll talk a little bit more about that shortly, there is a unique role that public health brings to the CCO conversation. So, for example, CCOs, individual healthcare providers, might be looking at how do we get individual patients to reduce their sodium intake. But public health can work with the food industry to talk about how to reduce sodium in food overall. And so what clinicians can do on an individual level, public health can do at an exponential level. And I think marrying those strengths together really helps us be more likely to achieve our goals.
Mitch?
Thank you. A little bit. What we've done in the last, excuse me, I'm trying to deal with a bit of bronchitis. What we've done in the last two sessions of the legislature signals a metamorphosis in the public health system that hasn't happened since the fight of communicable diseases in the early part of the 20th century. Right now, local public health has been relatively schizophrenic, dividing its energy between providing health services for people that haven't had access to other places in the healthcare system, and doing the more traditional population-based public health activities, epidemiology, disease prevention, variety, things like that. At the same time, there's been an extraordinary metamorphosis signaled by the CCO movement in the way we deliver clinical services. I did a commencement address at OHSU about 15 years ago now, where I urged the development of a change in the way we train healthcare personnel from having a set of individual-based clinical obligations to having a set of population-based clinical obligations. I said healthcare providers need to be thinking not only about their obligations to one patient sitting in their office or sitting in a hospital bed, to a notion that they, as individual healthcare providers, need to think about the population context within which that patient came from. That sounds a lot like public health. And as we move to CCOs and the health insurance exchange, I don't think you want to forget that, both things we've done fairly recently, we've pretty much provided a framework where at least every legal resident of the state of Oregon should have access to an individual healthcare provider through a CCO or other kinds of organized healthcare systems, and therefore, in the model we have for the CCO, should have access to population-based services as well as to individual-based services. At the same...
Excuse me, Mitch. I'm just going to turn this so everybody can hear you in back. Thank you.
Yeah, well, it was whistling when we did that, so let's see how it still goes. The other point that I want to make when we talk about it more as we answer questions is that this isn't something that just happened in the last 2 years. The movement we've had in this system, particularly in providing health care services for the Medicaid population, really began in 1988 in a commission Governor Neil Goldschmidt designed, named a Commission for Health Care for the Uninsured, which actually provided the framework for the Oregon Health Plan, which a obscure Senate president named Kitzhaber picked up and ran with it and did some extraordinary things with its implementation. When I first came to the legislature in 2003, we were struggling with how to save the Oregon Health Plan, and there were things that were done by Ben Westland, Al Bates, Jeff Cruz, who led the way to providing a hospital tax and strengthening the notion of fully capitated health plans, population-based healthcare systems for caring for the Oregon Health Plan. And in 2005, 2007, 2009, with the development of House Bill 2009 that created the Oregon Health Authority, and the beginning work on an exchange, at least the early work, 2011 and 2012, this has been a river of change, both in terms of the delivery of individual healthcare services and in the delivery of population healthcare services. We're going to have a lot to do to keep that river from overflowing its banks while it moves on downstream.
I'll just do it this way. It's easier. Thank you for inviting me. I'm not sure how schizophrenic we are, but we'll keep working on that. I do think from the local level, I have been doing this a long time. I have a lot of heart and passion about public health. And I think, when you've been in this for a while, you can really see the changes over the years. And it has been a little bit up and down on how we blend with the medical community and how we try to work together. And I think we have to be intertwined to make this work. And I think if I was at a meeting last night with our CCO applicant and with other public health directors and oral health directors and others, and we were really looking at what needs to happen in this application and how do we work together to make this happen. And I think those are the kind of things I'm really proud of, because for the first time in my career, we're all sitting at the table and we're all talking about how do we improve the health of our community. And obviously in Central Oregon, we've been working on this for a while. And I think for the public health side, part of it is, as my peers know, is I keep saying you have to be at the table. You have to be there and show what public health can do. And I know for us, we spent a year putting together our community assessment. We have a health improvement plan. Part of that is due to Senate Bill 204, but which just applied to Central Oregon. But I think that's when those are released, it's great documents that we can use to build what happens in our community. And I think some of this work really takes me back to thinking about really our core functions, assessment, when we think about policy development. And I know even at the table last night, I kept saying, well, think about how we can do policy around this. So it's not just about how do I take care of this patient, it's what are the policies and other types of things that we can change the environment to also make it healthier for people in our communities. And I think that other piece of it that's really important to me is assuring that individuals get service. And you know, when we go to, you know, Project Connects, and when I see thousands of people come in and they don't have services and they're in pain, it's really important that we make a difference in our communities. And I think that, you know, we have the tools to do this, and I think public health has the skills and the tools throughout this whole state to really step up and make a difference in our health. Thank you.
Well, thank you for having me as well. Certainly an honor to be here. I think my comments would just add on to a number of remarks that were already made. But the first one that Bruce talked about is that a lot of this work that we've done over the last couple of years really has focused on this shift from healthcare to health. And that really has been the overall theme. And when I was thinking about this today, the graph, the pie chart, many of you know this probably much better than I do. There's the graph that shows the factors that influence health status. And when we think about health, I mean, to me, this is just kind of a fundamental piece of us, that we know that 40% of what drives health status is really individual choice and behavior. We know that about 30% is driven by genetics and 20% by kind of social factors of, you know, where you live, education, networks. And then 10% is really driven by the healthcare delivery system. And what's unfortunate is that probably 99% of our time is spent on that 10% piece of the pie, and we can never really get to the overall outcomes of health. So when you think about it from the public health perspective, and I think even Representative Greenlick's comments around the schizophrenia, I mean, part of that is just the game. Think about the game of health. It's rigged against us. We can never achieve that because we're always focused on this acute care system, focused on how do we get paid for hospitalizations, how do we get paid for doing more tests. So I think what we've really tried to capture within the CCO movement is how do we get away from that? How do we actually change the rules of the game to work within a global budget, to work within one point of accountability, and to work within some set of core metrics that can actually start to drive us down this road to health. So I think that gives me much more optimism than I've ever had before. But I think ultimately we're talking about a change of plans, a change of business plans from everybody, whether you're a health system, a health plan, or a public health department. I mean, this is a shift, and I think the CCO structure is really starting to allow those conversations to begin like we've never had before. So again, I remain optimistic. I think a lot of this success is going to be built on the knowledge base from the public health community of how do we actually do some stronger outreach and community health needs assessment, and that's going to be a core, I think, a core competency that's going to be needed within the CCO framework. So, thanks.
I think I'd like to start with a more general question and open it up to any of you. What are some more specifics about the roles of state and local public health in working with CCOs?
We really stepped up and said that when we looked at our Tri-County area and decided what we wanted to do, we really said we are the lead in community assessment. We will take the lead. We will call the partners together. We will, work on the data, work with the state, and work with a group to bring that together, and really thinking about pulling partners from all 3 counties. So it is tedious work at times. You have lots of different people at the table and lots of ideas, but it all brings it together to make a really good report. And I think the other piece of it, with community assessment, we've also, in our region, we're also trying to combine it with the early learning work. And so we've brought the commission into it as part of our work, and really looking at how do we bring these 2 systems together, because kids are kids and their health needs to be involved in that, and it can't be in 2 separate worlds either. So I think those are some of the things on community assessment. As far as the other piece was, we also brought the community partners together for the regional health planning part. So when we really looked at the community assessment, looked at the 10 things that rose to the top, and then we created a health improvement plan. And it's not just a public health improvement plan. It's talking about kind of traditional public health improvement plan. We had the hospitals involved. We had the physicians involved. We had many, many partners to come up with this health improvement plan for the region. So it's and it was challenging, because it's a really different model than what you're used to doing, especially when you have 3 counties that, if you look at the county health rankings that just came out this week, Deschutes is near the top. I'm sort of in the middle in Crook, and Jefferson is near the bottom. And we're working together as a tri-county trying to figure this out. So those are a couple examples. And then also I've been working really hard with the CCO, or actually Specific Source, on their application, and kind of as a group, Central Oregon Health Council, how we wanted to move forward. So
Muriel spoke really well about sort of the role in Central Oregon. I think we don't know where and what the roles are going to be. I think it's going to evolve. Right. And I think it should evolve. We know we have 34, 35 local health departments in the state.
34.
34? I know, it's close. And they do a variety of different things. Some deliver primary care, others don't. Some have strengths that others don't have. I think that the notion of the coordinated care organizations is that health and healthcare is local. And it is really about pushing the accountability and the responsibility around local communities. And I think when you look at it from that perspective, not all of our local communities are the same. And what that means is that I think there'll be the same accountabilities for health. But what the roles are of local health departments in those communities may really vary from one area to the next. I don't think we know. And I know that as the legislation and the planning for this has moved forward, it hasn't been explicit, and I think it hasn't been explicit with good reason, because the notion is for communities to figure out where their strengths are, what they need to do, how they need to work together, and be able to do that in a way that best brings about the accountabilities that we're looking for.
Are there some ways public health can help make that happen, do you think, Bruce?
I think, yeah, I think in several different ways. One, it's certainly by doing, I think, what I've seen happening all around the state, and Muriel just alluded to, which is by being a collaborative partner. And that's probably the biggest and the best way is to say, here's who we are, here's what we have to offer, here's how we can contribute, and to bring those skills and that expertise to the table in what's happening in local communities.
Mitch, and then
Yeah,
Tricia.
I'd like to comment on that just a little bit. When I studied economics, I learned about Greshams Law, which was that bad currency drives good currency out of circulation. The issue here, we're in a room where we all know public health is really important and wonderful and does great things and matters. We all got our degrees to prove that. We believe that. But the fact is, on the ground in the CCO, we're talking about blending all sources of revenue that relate to health and health care into a single stream of funds. And the decision on the ground is going to be, how do you distribute these funds? And if I'm trying to organize a CCO and a health director comes to me and says, well, we can do community health assessment, give us this money to do that, my answer is, I don't give a damn about community health assessment. I have to deliver services to these people who are knocking on my door. The challenge for public health, and it's going to be your challenge, our challenge from the public health side, is to really make sure we can deliver things that matter to the people who are making the decisions about how resources are distributed. And that means being really hard-minded and hard-nosed about what it is we can deliver to the task that the CCOs are going to be held to. I mean, that really means, look at the matrices that Bruce and you all are demanding as, here's what it takes to succeed, and figuring out how you can provide things that will move that CCO towards being able to achieve what its responsibility. And the truth is, it's not used to doing, the people who are involved in this aren't used to doing that. They're not used to answering those kind of questions. So I think it's a very possible, I think we in public health can bring value to the CCOs, but we have to get very explicit about it. And it's not about looking up on the wall and saying, what does public health do? It's a question of, what job does a CCO have to do? What do they have to produce in order to succeed? And how can we help them do what it is they need to do in order to succeed?
I think part of that is the message that public health brings too, because as Mike mentioned before, if only 10% of health is attributed to health care, but 99% of our time and effort is focused on health care, it's very easy for the conversation to go to the status quo, which is that clinical service delivery. And I think the message that public health, regardless of the community, regardless of the individual local strengths, the message that has to be consistent is that we've got to think about the person in the context of their community, not just in the context of their clinical environment. So when people leave the clinical environment, what's happening in the community that either supports a healthy message or doesn't support a healthy message? And I think public health does bring the research and the tools to be able to think about how does that person engage so that the healthy choice is an easy choice, so that the CCOs can understand what's the return on their investment. If they are making a choice to put money into something that's not traditionally clinical, how do they know that that's going to pay off? And I do think that that's the role that public health brings, is to share those answers to those questions.
Oh, go ahead, Mike.
Mike.
Okay. I wanted to give a clear example of one of the things we talked about last night. We talked about the importance of getting to pregnant women early and making sure not only that they have dental care and all types of things about prenatal care, but one of the things we talked about specifically was the idea that many of those women are in WIC. How do we coordinate? So that's kind of a direct type of thing. And I think one of the things I've learned by being on a prevention committee with the medical director from Pacific Source is that there are all kinds of things we do in public health that they don't know we do. And that's been one of the real learning moments, I think, is they find out what we do and how do we help them and how do they help us. And that has been one of the real positive things that's happened in this collaborative work we're doing.
Just one final thought. It was just to add on to Representative Greenlick's and Trish's comments. I think Representative Greenlick touched on something in terms of how we need to look at public health being responsive to a CCO's needs. And Tricia just talked about an ROI. And I think that is so important, and I think it's just a different mindset that all of us need to have. And Mel and I have had many conversations about this. That one example that I have in particular has to do with the program Living Well with Chronic Disease. Great program, outstanding program. Problem that I've seen time and time again is that we have these programs that are grant funded, and they have some great success over a 1 to 2 year period, and then they're gone. And I feel like we just haven't done a good enough job of actually demonstrating a solid ROI where we could go back to a CCO executive team and say, this is the investment that you want to make on the upfront investment on prevention, because you're going to get that return. And I think this is just a different frame that we really all need to be thinking about, because that's what's going to drive those conversations within a CCO budgeting process.
I remember last spring in some of the meetings being struck by some of the comments, and one healthcare leader in particular I remember who said, how can we be held accountable for things over which we don't have control? My first reaction was, of course, welcome to my world, because most of what we all deal with falls in that category. But, it was a very legitimate question from a business-focused person. So how do we work on changing that? Do you have some tips for us as we work with the healthcare community, healthcare executives around these kinds of issues, how we approach them and talk about this in ways that will resonate? I hear the ROI comment, I think, very, very well made, but other ideas?
Well, I'll just start quickly. I think the first thing that I think is going to be essential is everybody having a core understanding of the metrics and the accountability side. And I think that's when I think public health can actually step up and say, based on some population health metrics that these CCOs are going to be held accountable to, this is where we can actually help you attain some great numbers. Until that time, I think people are really going to have to understand how they can come together. And I think this metric piece, you're going to have a lot of CCOs who have been embedded in a clinical model who don't necessarily have that expertise on the population health side. And I think that's an opportunity that you're going to be able to bring to the table that we haven't had before.
And just to piggyback on that, sort of a dose of reality, I think, for all of us as we go forth in this, which is that, we're putting together these CCOs, a new way of looking at care. But we're just starting. B, we're focusing this on right now 12 to 15% of our state's population. And so when we talk about accountability for health, we have to be really mindful about where we're starting. We're starting, I think, in the right place, where we're piloting this. We're taking 12, 15% of the population. We're trying to be certain that this works, but I think we have to just be realistic that when we talk about accountability and accountability for health, suddenly we're not accountability for this. This isn't about being accountable for everybody's health everywhere, but it's a start, and it's a start for a new way of all working together. I guess the last comment I'd make around that is it's been interesting to me, the notion of accountability and responsibility. There's a lot of hands in the air when there's a sense that this is about, I get to get resources to be accountable for this, and there isn't when there aren't. And it's been interesting to me as we've gone around the state and as I talk to groups. Muriel was talking about women's health issues and WIC and the role that local public health plays in that. I've talked to 3 other groups in the last 72 hours who all have felt that they're responsible and accountable for the same issues. Professional groups, community organizations who deal with these. And we have in our healthcare system a lot of people that contribute to women's health and nutrition and a lot of the same things that happen in our local health departments. It's not the only place it happens. It happens in all sorts of places. If you go talk to a group of pediatricians, they'll tell you they are responsible for children's health. And if you talk to some of our people who work in state and local public health, they'll tell you we're responsible for maternal child health. And, my question is, okay, who? And I think the issue is we all are. And the notion now is let's have a good, honest conversation about who and how we can really, I know it's maybe beginning to sound a bit cliche, but how can we coordinate those resources? We have a lot of resources in our communities. We often don't coordinate them and use them in a way that makes a lot of sense. And I think part of this whole movement forward is to give us some of the structure and ability to do that.
Now, I'd like to put a cautionary word in. Bruce has smiled at me talking about the AAA movie or whatever it is.
Mumbo jumbo, I think you called it.
AAA mumbo jumbo. I think we ought to be pretty cautious when we talk about health. And when we're talking about health, we're talking about function and we're talking about the avoidance of disease. We can't let the perfect be the enemy of the good. So the real point that I try and make when I talk about the AAA mumbo jumbo is to make sure we're talking about proximate measures of health, making sure we're talking about things that we can actually hold a community responsible for. I mean, for example, just I think as an example from my research experience, if we're trying to prevent heart attacks in men 50 to 60 years old, what we need to be doing is making sure they're not smoking when they're 30, making sure their cholesterol is under control, making sure their blood pressure is under control. So, in a sense, we want to be very cautious about, for example, talking about the heart attack rate, change in the heart attack rate as an outcome for this year. What we need to be talking about is what have we done for the proximate measures that are really necessary? Have we gotten women in the first trimester of pregnancy and gotten them linked to the kind of nutrition and other services they need? And are we dealing on a preventive way with something that may not pay off for a CCO this year or next year or the next decade, but is the right thing we need to do? Smoking prevention has a little short-term payoff, although it has some other things. I mean, people who are smoking don't like to go to the doctor because they don't want to hear the doctor tell them that they should stop smoking. But what we need to measure is, are we getting people to stop smoking? And what role is the public health, is the community having, and is the personal health services side having? For example, in the personal health services, what we ought to be demanding is that doctors are using smoking as a vital sign and are giving a 3-minute message about it to every person they see. And then making sure they're referred to community resources that can carry that to the next step. But we need to be pretty cautious about how we give those responsibilities. And you're going to define the role of public health to a certain extent by what you begin to hold them responsible for.
Mitch, I want to push back a little bit with you around this.
No,
I know you won't. You can take it. I mean, there's good research to show that having a healthcare provider ask and provide appropriate referral, the 5As and so forth, is very, very important. But only if it's done in the context of a robust community tobacco prevention
No, that's
program.
the point I was making. That's
okay.
Right,
So
they need to have a piece. They need to be asking. It's a very important thing to ask in the healthcare side. Are you smoking? And if you are, it's time to start thinking about it. And here's where you can get some help. Yeah, if they don't do it within that notion of here's where you can get some help, it's not going to be much use.
I guess the point I'm making is one about resources, and because accountability is tied with resources often, hopefully. So who's going to fund those community-based efforts? Are those the kinds of things that CCOs might fund in the future? Is that part of the vision for this?
Certainly part of my vision. Yeah, absolutely. I mean, the stream that we're putting the resource stream into there has been streams that have been used for these kind of things. And the purpose isn't to rip them off, to do something else with them, is to augment them in a way that can be useful to allow the CCOs to achieve the outcomes they need to achieve.
We're going to need to transition from where the resources go today to going to such things as community-based prevention. Having said that, that's not going to happen August 2nd. But I think what we're doing is beginning to create that transition. We've talked about, you mentioned coronary care. You know, one of the examples we have been talking a lot about is about coronary care and how our system right now is focused. Our healthcare system is focused and reimbursed on filling coronary care beds. But you all know what the best coronary care bed in Portland is.
It's a home bed.
It's an empty bed.
No, it's your bed at home.
Exactly. That's exactly it. But all of our resources go to fill up those beds. And that's not being critical of the business model of hospitals and our healthcare system. That's just the reality. We clearly need to start to change that, but that's not going to happen overnight. We're not going to divest all of our funding in coronary care overnight and have people not getting the kind of coronary care that they need. But ultimately, we all know that this is a preventable illness, and that hopefully we need to have some goals and some metrics as a state and as a society to say, here's where we're going to be in terms of preventing these kinds of preventable problems, and here's our strategy to do that. And I do believe that CCOs need to be a clear part of making the investment in that. If they're only going to invest in the interventions that we could prevent, then we're not going to in any way succeed.
It goes back to that message around the person in the context of their community, not just the context of their clinic. So if you're talking tobacco prevention, you can't just think about the smoker when they come to the doctor's office. You have to think about what happens when they leave the clinic. And I think, again, that's the message that, so public health, whether on the governance level of CCOs or the community advisory level, that voice has to always be there, because it really is a culture shift to bring the clinical system to think more about what's happening when people leave the clinic.
Go ahead.
I also think one of the real positives that I think has come out of this are the conversations happening in communities. And on Monday, I did a public health luncheon. We gave some awards, and we had the mayor and a whole bunch of people from Crook County there. And it was really exciting because last year we talked about doing a health impact assessment with the city of Prineville and on walking and bike path, knowing that the path in our community really needed some work. Using the data from that, they just got a $600,000 grant to improve the walking and bike path. And so those are the kinds of things I also see as a huge role for public health. The planning director in Prineville is now my new best friend. So I think those are the types of things that public health uniquely does, and does some of that work that is very different than anybody else. But I think a lot of this work, and as I'm working with the CCO, is really thinking about how do we bring other partners into this conversation. How do we bring these physicians in, or these physicians from Prineville? And I think we kind of play a conduit for that. And maybe not everywhere, but I think I'm just really vocal. So in our community, it's really how do we bring those people to the table and help them so it's open for everybody. And I think the other real positive that I've really seen is our county commissioners are so all over this now. I mean, they now know about public health. They know what's happening in public health. And that's also been a huge difference from, I think, well, through my public health career, kind of getting the commissioners to talk about public health wasn't always at the top of their list. So I think that's been one of the pluses that's come out of this.
You know, I think that's a really important point, Muriel, and to my mind, one of the real achievements about getting this whole CCO bill passed was that it was done in a bipartisan way. And that's really, really important, and I think something we're going to need to continue to work on. I want to make sure we touch on two other topics before I open it up for questions from the audience. The first is, 40%, Bruce, you mentioned that this is being piloted, rolled out for the Medicaid population. 40% of Medicaid clients are people of color. So what does that mean about what CCOs ought to be doing or should be doing? The issue of community health workers, how might public health contribute to developing that tool around the state, and also related to that, working with the tribes and Indian Health Service. So, anybody want to make some comments about that?
Well, I'm happy to start the conversation about health equity and the role of public health. And when I was thinking about this, I go back to the 10 essential services of public health and think about, so monitoring health status. Well, how do we do that within the lens of health equity? That means we have to actually be collecting demographic data by race, ethnicity, language, and beyond, right? Occupation, so that we understand what are the health impacts that are unique to migrant and seasonal farm workers, as an example. Informing, educating, and empowering people about issues. So that means we need a workforce that's informed, educated, empowered to think about health equity issues and has relationships, trusted relationships with diverse communities to be able to engage in that discussion and dialogue. Mobilizing community partnerships. So when we talk about doing community health assessments, who are we talking to? Are we talking to people who are the usual suspects? Or are we doing what we need to do to go the extra mile to engage communities that have been disenfranchised? And I think that when we think about the Medicaid population, these are the most vulnerable Oregonians. They're vulnerable because of income. They're vulnerable because of poorer health status. They're vulnerable because on top of that, there's issues of racism or just other types of marginalization. So they're not necessarily the go-to communities when we think about who are the power players when we're talking about health systems change. So there's really an opportunity, I think, for public health to think about how do we build those bridges. And I think local public health has been doing that. I think the state's been doing that. And there are some really clear examples of people who've made that investment to really think about health equity, culturally competent care, making sure that there's language access for care. So I think that because of some of the language in the legislation, there are some pretty clear pathways, like using healthcare interpreters that are certified and qualified and community health workers. But I think really it's about having at the leadership level a philosophy and that commitment to closing these avoidable health gaps.
Any other comments? Mike, did you want to say something?
I would just add on to that. I mean, I think it's a great opportunity for us to look more seriously at the accountability. I mean, I think it's one thing to have the data, and we look at the data, we understand the disparity and the discrepancy, but what do we do with it? What can we do with it today? And I think that, the answer right now is actually very, very little. So again, I kind of get back to the metric side. If we are looking at holding entities accountable for specific health improvements and, dealing with the equity and inclusion piece, that is, to me, again, changing the rules of the game that we've never done before.
It certainly stains us as a state and as a nation that we have disparities in health and health outcomes based on people's race and ethnicity. And I started this by saying one of the explicit things about the legislation and this movement was it explicitly talked about health and set that as a goal. One of the other things it does is it explicitly calls out health equity and disparities as goals that we need to address. I think that's a great charge for us. I think that, again, harking back to what we talked about health and 12% of the 15% of the population, this is a great start. And I think it's a great way to start, to be clear and explicit that this is one of the goals and the outcomes for a Medicaid system. It's some of the goals and outcomes for our CCOs. It's something that we do need to develop the expertise, the accountability, and the ability to deliver on. And it's going to, I think, challenge us, and it should, to do that and to change a lot of what we do. And I think that it's, really one of the things in the legislation that we can, I think, point to with, some pride in seeing it there. Now it's up to all of us to deliver on it.
So the one last topic I want to make sure we touch on, Bruce, you referred to the transformation of the public health system. We've been talking about a lot of things that are about, sort of external to public health and how public health engages with external partners. But what about internally? What do we need to do to get our own house in order? Accreditation is one of the activities that both state and local public health are very actively engaged in. Any thoughts about how we transform ourselves to be able to support CCOs better, beyond what folks have already mentioned?
Is this one for me?
It's for anybody, all of it. I need all the help I can get from you also.
I can talk a little bit about accreditation because to me one of the things that was a little bit discouraging to me when I looked at the accreditation standards for public health. I think it's great that there's a minimum standard for quality for all public health departments, local and at the state level. The piece that I thought was really missing was an explicit focus on health equity and cultural competence. And I've just really enjoyed working with Chloe on building those pieces into the accreditation standards. But I think that if we're really talking about a workforce and policies and standards that help us meet that goal of the prior question around health equity, there's a lot of work to be done. It's going to take a lot of intentional focus for the public health field as a whole, because these aren't Oregon standards, they're national standards. So for the public health field as a whole to be thinking about building capacity around health equity.
Mike?
I think this is my earlier comments. I think this is a time to rethink the current business model around public health. And as you think about, Bruce was alluding to, we have kind of a lot of just differing models that are out there. Some, health departments are really in clinical services. Some are not. But when you take a step back and look at this, we know, Representative Greenlick can tell you, we know funding is going to be going down. So to live in this same paradigm, I think, again, you're kind of just going down a road that's unsustainable. So how do we, within public health world, look at a new framework, a new business model, to look, I think, seriously at the core competencies that we talked about earlier. And if you're looking at in a supporting role for a CCO in terms of, the assessment and, I think community health workers and a lot of that stuff is going to be essential. But I think the clinical arena, I think, is going to be a challenge if we're going to be looking at coordinated care within a medical home type of structure. I think that's going to be a challenge. So I think that's one area where I would really kind of encourage us to think differently about public health.
I think 34 public health departments in this state is absurd. I think 36 counties is absurd, frankly. I've had a bill in, for example, to merge the 3 counties in the metropolitan area into a single county. 3 health departments in this county, it's nuts. And 34 health departments. I think maybe half a dozen health departments around the state with some number. I'm not sure what the magic number is, but we just can't support 34 health departments. And many of those health departments just aren't going to have enough people to do public health functions that we need to do. So I think we just need a whole different view of the way this service is organized in the state. And I think it's something we need to be talking about. I think core function is really important. The health department should be stop delivering personal health care services. We need to find a much more efficient way to do that. And I think the world has to change. And I think we have to change our own world. We still live in maybe not a 19th century, but an early 20th century model. And the model just doesn't work. we can't sustain it. We can't put the resources into it. So, I mean, I think we need to ask ourselves, how do we revolutionize the delivery of public health services in this state? What can we do to do what are these core functions? Or maybe we don't need 10 core functions. Maybe we need 6 core functions. I mean, the world has got to change. And it's got to change in the same way that we're demanding the personal health care service change with things like CCOs. I mean, we just can't keep doing it the way we're doing it.
You know, the funding structure for public health is probably as dysfunctional as individual care. And so when we talk about transforming public health, let's look at 2 different analogies. We've talked about coordinated care and who's responsible for coronary care. Is it the cardiologist? Is it the family doc? Is it the left side of the heart cardiologist, the interventional cardiologist? Who is it that, I mean, we know the individual care system, we're fragmented, there isn't accountability, it's overly specialized. But let's take a look at our public health system. We're driven by fragmented funding streams. So when I look out in the audience and we talk about heart disease, who's responsible? Is it the smoking program? Is it we know a lot of your health is determined in utero. Is it going to be what happens in terms of WIC and a variety of those programs? Is it our chronic illness program? Is it the myriad of different programs that we have which are driven by an absolutely fragmented and dysfunctional federal system for funding public health, which puts us all in silos and which is absolutely the antithesis of the health of a community? We have a public health system that doesn't fund public health. It funds, you could all raise your hands. You're all involved in 27 different streams of public health, much like I could go to
It's actually 120, but who's counting?
Yeah.
I could go to a group of doctors and it's the same thing. You've got the hand people, the neck people, the eye people, the this people, the that people, and no one's responsible and accountable for the health of a person. That's part of why we've gotten ourselves in this mess. That's part of why we're in this mess in individual care. And quite frankly, when I think about the transformation of our public health system, it's around some of the same things. How do we stop living in a world where it's determined by these funding streams and what we do rather than by the outcomes and what we need? And I would imagine if it weren't for that, we would all start to think about public health a little bit differently. And it's time for us to start to do that. I don't know what the answer is, but I think it's a wonderful opportunity for us to begin that conversation, because I don't think the answer is what often people say. All we need is more money. I think the issue is we're also not using all of our public health resources, much like we're not using all of our healthcare resources in the best way possible. Having said that, we do need to move those resources from individual care into public and population health. But let's not just put them all in the same system we've got going now, because if we do, I'm not certain we're going to be successful.
Muriel.
Okay, I have to respond.
I probably now lost my membership card.
So a couple things. First of all, I think as a state, we are about 47th for general fund for public health. So that is one thing. I think the other thing that's really important for me, you can tell I'm a little passionate about this, but public health is local. And yes, there are things that we can do to improve. There are things we can do to look at the system, and I'm the first one we're doing a lot of things in Central Oregon, so I'm the first one to look at a system and say, how do we improve this? But it doesn't necessarily scrap everything we're doing. And I think the most important part for me is that it still is local.
Why is public health local?
Because the people in that community are the ones that pay the taxes, that look at what we're giving them. And they have ideas. If we make this top down, it doesn't work. I mean, it really doesn't work. And and I guess I'm one of those public health directors that really listens to my community, and then I make changes in what I do based on that.
But most public health is about changing society. I mean, it's about how cigarettes are marketed, for example. Is that a local issue? It's not. It's a national issue. It's a state issue. But it's
also a local issue.
Yeah. Okay, so public health is also local. I accept that. Is that what you're saying?
Yeah.
Okay, I buy that.
I'm saying it's more local than anything else is what I'm saying. So I do, but I'm the one that has to go to my commissioners and talk to them about tobacco policy and have many other people in the room that may not agree with my opinion. It's just important.
Isn't that part of the problem? The problem is that we've named by law the county commissioners as a public health authority for a county. I mean, that's dumb.
Well, I don't have a problem with it, but
I think
we'll move on.
I'd like to. This would be a great discussion over a bottle of wine or something.
Yeah, exactly.
Or in the legislature.
Yes, absolutely.
Which is
we'll look forward to that
discussion in the next session.
Carrot juice.
Sorry, carrot juice. Yes, wrong analogy. Yes. I would, so now I'd like to, we have a couple of minutes for questions. We do have one from the phone I'd like to start with. I don't know who this is from, but I'll just read it. In rural areas where population is lower, will there be consideration given to the difficulty in gaining critical mass of patients into the CCO for shared risk?
Yeah. This is something we've been talking about a lot with a lot of communities. Both rural and non-rural. There are some ways that we, as the state, are looking to be able to mitigate and share that risk with smaller communities, whether that's through a statewide reinsurance mechanism or some other ways. But indeed, I think we're looking for communities to be accountable and to take some risk for healthcare. Some communities, it may not be just simply the size, it also may be the experience. And so we're looking at some ways to be able to provide opportunities for communities. Also, as I've been around the state now in different parts of the state, there's a variety of communities that are sort of joining together and pooling. So I think there's going to be multiple opportunities to be able to manage some of that risk.
Okay, so let's open the floor for questions. Just question was, will the prioritized list that's currently used for the Oregon Health Plan, what role will it play, if any, in the CCOs?
The prioritized list remains the prioritized list of health services for the Oregon Health Plan. That's not changing. What is hopefully going to change is how care is organized and delivered around those sets of services.
Yeah, but let's make sure what the prioritized list is what creates the premium, if you call it, that goes to the CCOs. It's not what they have to deliver. I mean, for example, if the removal of stitches isn't on the priority list, they're going to still do it. They won't do a brain transplant if it's not on the priority list, but I mean, it will be up to them to figure out how to use the money once it's been given to them, right? I mean,
correct.
That's the important point. Once they get the money, it's up to them to figure out how to deliver services.
Well, I hope none of our CCOs are doing brain transplants, because I think that's pushing the envelope.
Well, no,
I understand what you're saying.
They wouldn't, because they're probably not covered by Blue Cross either.
Okay.
Although.
So the question was, many counties are very strapped financially right now, and is there anything we're doing at the state related to preventing supplantation of county funds that are being used to support public health in the context of CCO development?
Let me take that from a different. Let me flip that around, Grant, and put it in a different perspective. we know that there are a lot of counties that put resources into public health and into supporting the health of their communities. We also know that there are a lot of counties that don't.
Yeah, that's true.
And that's the truth of the matter. And I think that what we'd like to see is counties, communities engaged in the health of their community. And in, as I indicated, figuring out how it is that we coordinate all of these resources. I think in the end, if we're successful, and this is, way out into the future, that we're going to create the kinds of environments where we're not going to be worrying about how funds are supplanted, but where we're going to be engaging counties and communities to make the kinds of investments in the health of their community, because that's where they live, and they're going to see the value of those investments. So I think and I hope that by having this be local, that we actually help, I think, mitigate some of the ability to sort of absolve ourselves of, localities absolve themselves of responsibility. And I hope instead it really draws them in and helps them be participants.
Okay, I think we had one more question here. Be our last. So the question was, how are the CCOs involving people on the health plan in assessing what it is that they want from the CCOs? Right.
Consumer representation.
Yeah, there is a consumer advisory council that's part of that structure, and so I think that's part of the requirement of the CCO. And I think that actually we're working on that right now and kind of developing that group. So
I think there are a couple of strategies that are also written into the legislation around CCOs. For example, utilizing a workforce that includes community health workers or healthcare interpreters. Those are individuals who not only can provide a health message, so one-way communication, but are also very closely affiliated with the communities that they serve. So there's an opportunity for them to gather information in to also impact how care is delivered. And I think that is a part of that. I think also that patient-centered primary care home model really involves listening directly to the patients, not only just the demographic, but the data as well as the patient experience, and thinking differently about how do we assess patient satisfaction. It's not, was the room warm and was your provider nice, but really, did you feel like you were listened to, were you heard, and then how do we use that data to modify and improve our practice?
I think that's a great point. I think the other thing that I would highlight is that we don't have any CCOs yet today, and I think it's a big takeaway. I mean, we still have some work to do, and we just have letters of intent that were submitted the other day. We now are obviously going through this application process, and part of that, what we tried to lay out just with the CCO criteria was this level of community engagement. But I think your point is right on, and I think during this evaluation process, we want to make sure that people are actually reaching out and understanding what their members' needs are.
Yeah, I mean, what you said was obvious and brilliant. The definition of health has to be what people think health is. And I think we all have very different views of health. I mean, I have a health questionnaire supposed to fill out, and one of the things I filled was my health excellent, good, fair, or poor, and I checked, excellent. And then I thought, well, wait a minute, I'm a lymphoma survivor. I've been coughing for 2 months. I can walk about 2 blocks without getting tired. All these other things. All right, good.
Okay. I want to, boy, Mitch, I don't know how anybody could top that.
I know, exactly.